Thanks for the invite. So I'll be talking a bit about the advances in the management of endometrial cancer when less is more. And I'll cover three aspects of what's new in the management of endometrial cancer. Right. So what is endometrial cancer? Endometrial cancer is actually the fifth most common cancer in women globally. Right. And there's a very high incidence, especially in developed countries. Like, for example, in the United States, 19 out of 100,000 women are diagnosed with this cancer. In Singapore, it's also very common, for 13 per 100,000 women. That's why in Singapore, it's actually the fourth most common cancer affecting women today. It is associated in particular with rising prevalence on obesity as well as metabolic syndromes such as diabetes. And unfortunately, most of the women who are diagnosed are postmenopausal, that means above the age of 50. But fortunately, we are able to detect them early, as 75% of cases are diagnosed at early stages. And the prognosis is generally very good if the cancer is diagnosed early. So the standard treatment for endometrial cancers has been for a long time, and it is today as well, total hysterectomy, removal of both tubes and ovaries, as well as lymph node dissection. Well, however, in the recent years, right, we've been exploring minimally invasive techniques for this surgery, and large studies in the United States showed that actually, if you do it through laparoscopy, it's shown to be inferior at all to the traditional open route in large randomized trials. So the overall survival after 5 years is the same. Of course, for minimally invasive surgery, there are criteria. So essentially, it has to be early disease. Then we can do through either the laparoscope or using robot-assisted surgery. And then uterus cannot be too big, otherwise you cannot remove the uterus through the vagina. And preferably, the patient is not a verbal intacta, and there must not be any contraindications for this minimally invasive surgery. Okay, so but of interest in the last 10 years, right, is the Sentinel node mapping and biopsy for endometrial cancer. In endometrial cancers, the lymph node status is extremely important because it is a predictor of survival and also guides post-operative treatment planning for patients. Patients with lymph node positives are considered advanced cancers at stage 3. And okay, so sentinel node mapping, although it's first reported in medical literature in 1996, it's only gained clinical acceptance only in the last decade. It has been shown to be very safe as an alternative to full lymphadenectomy for presumed early stage cancers. Meta-analysis showed that it has an extremely good negative predictive value of 99.7%, with overall detection rate of about 81% and bilateral detection of 50%. And in the recent studies, right, called the FIRES trial, which is done in the United States using the robot-assisted surgery, they showed that it has extremely high sensitivity of 97% and bilateral detection of 86% and negative predictive value of 99.7% using a new technique called indocyanine green near-infrared detection of sentinel lymph nodes, which I'll show later. So what's a sentinel lymph node? So it's actually the first lymph node that receives drainage from the primary tumor, hence is most likely to harbor metastasis. It's used a lot in early breast cancers, right? And of course, in breast cancer, they use the technetium-99 and as well as to actually detect the sentinel lymph node. If the sentinel lymph node is negative for metastasis, then we presume that the non-sentinel nodes are also expected to be negative as well. This is the lymphatic mapping hypothesis. So advantage of doing sentinel lymph node endometrial cancer is pretty obvious. There'll be a reduced incidence of lymphedema of the lower limbs. So we can reduce it from 20% all the way down to less than 5% if sentinel lymph node biopsy is performed for endometrial cancers. In lymph node mapping studies for endometrial cancer, we found that majority, 91% of the sentinel lymph nodes are actually found in the pelvis. That means the pelvic lymph nodes. Only about 5% or less are found along the parotid chain. right? And for sentinel lymph node mapping to be successful, it has to be bilateral. That's why we have an algorithm, the Sentinel algorithm, which all practitioners of this technique follow. This from United States. And for patients, right, when we perform Sentinel, we must excise all the mapped lymph nodes that are seen. However, if we do find any suspicious lymph nodes that are enlarged during the surgery, we have to remove them, regardless of whether they light up or not. Okay, this rule that we might have to follow. However, if the patient has no mapping on the hemipelvis, right, then we have to do a systematic removal of the lymph nodes on the side of the pelvis. Right? Parotid lymph node dissection is done at the attending physician's discretion. So I just show you this. This was one of the first cases was done in Singapore about more than 6-7 years ago. At the time, we used the first generation indocyanine green infrared system. So we have to activate the infrared camera in order to find the lymph node, right, in the pelvis. So we can see the lymph node in the right hemipelvis, right? If you turn off the infrared, you can't see, and you just see a mass of fat around the vessels. But with the infrared camera, we can locate where the lymph node is, right? So this is a technique we've been using for a long time. Actually, we started the lymph node mapping studies way back in 2016, and then we finally got our machine in 2018 and performed it routinely in Cape Hospital previously when I was there. In this case, this patient had 3 sites of central lymph node, one on each hemipelvis and one along at the lower parotid bifurcation. So this is a second generation ICG system, right? So this one is using the Rubina system, and the distinct advantage when we use this system, you'll see in a moment. Right, this is a right hemipelvis. So this time round, we can see the lymphatic channels real time, and we don't operate in darkness anymore compared to the first generation uh, machines that we had previously. So now you can see the lymph node. This one is a lymph node along the uh, right external iliac vessels. So by doing this, we avoid removing all the lymph nodes that we see in the pelvis, and this will definitely reduce the chance of lymphedema. So removing central lymph nodes is very good because it's highly accurate. So currently, it's been shown to be able to replace systematic lymphadenectomy for staging of endometrial cancers. What about the oncology outcomes? Is it really safe to just do central lymph nodes for patients with endometrial cancer? The answer is yes. Meta-analysis of a few thousand patients that was performed in 2019 showed that the recurrence was actually only 4.3% after SLND, compared to 7.2% after lymphadenectomy. Yeah, I mean, it's not that it's significant, but we find that one of the reasons is because when we do central lymph node, we do something called ultra staging. Ultra staging is done in the pathology lab where they slice the lymph node to very, very fine slices compared to if they do a conventional histology to look for micrometastasis. That's how accurate it is. So central lymph nodes appears to be non-inferior at all to standard lymphadenectomy in terms of oncological outcomes. Can it be used in high-risk cancers? Conventional high-risk cancers, right, we will still generally do systematic lymphadenectomy because the risk of a lymph node metastasis is very high for patients with high-risk cancers. High-risk cancer refers to patients with high-grade cancers, like clear cell cancers, carcinosarcomas, right, high-grade serous or high-grade endometrioid. The prevalence of pelvic lymph nodes is already 70% for presumed early-stage cancers and 12% for parotid lymph nodes. Yeah, so that's why for such cases, generally we still do a systematic lymphadenectomy all the way to parotid for these group patients. However, there'll be interest in seeing whether a central lymph node is also suitable for these cases, and in a recent meta-analysis, right, of our 9 studies. Of course, with a small number of 29 patients, they found that actually it might be feasible because the detection of 91% with bilateral detection of 64%, and they discovered 26% of patients had positive sentinel lymph nodes in these groups of patients. So there's a current interest now in seeing whether it can replace systematic lymphadenectomy for high-risk cases. But we're waiting the randomized studies for this group of patients. Okay, next I would like to talk a bit about fertility sparing, right? Fertility sparing. Yes. So as mentioned earlier on, endometrial cancer is mostly seen in patients who are older. However, about 3 to 40% of women less than 40 years old are actually diagnosed with endometrial cancer, right? And many still wish to preserve their fertility. And however, we do have a criteria for such group of patients, right? And only patients with grade 1 tumors, those are most likely to express this estrogen progesterone receptors, and they are more suitable for fertility sparing. But of course, in this group of patients, we generally advise them to screen for Lynch or HPCC syndrome, right? Because it may be genetic. Yeah, so other criteria, of course, other than being young, strong enough to preserve fertility, they have to be clinically a stage 1 patient and 1A without vision on imaging. Grade 1 and maybe pushing a bit to grade 2, and no clinical evidence or imaging evidence of any spread before we can offer this treatment. And we have to inform the patient that this is not standard treatment for cancer of the uterus, right? Because there's no randomized trials at all for fertility sparing. Right? We only have prospective studies. What do we use for this young women who are trying for children with early cancers? Progestins is the most common method of treatment. And the one we use in Singapore is migestrol acetate. We start with 160 milligrams per day, up to 320 milligrams daily. In some other countries, they use high doses of Overa, hydroxyprogesterone, very, very high, 300 to 600 milligrams daily. Just for comparison, for menstrual disturbance, whatever, we only use like maybe 10 to 20 grams twice a day, 3 times a day for treatment of menstrual disorders for hydroxyprogesterone. But for cancer treatment, we use 10 times the dose. So, of course, the risk of using high dose progesterone, of course, is there, especially in particular, deep vein thrombosis, pulmonary embolism, weight gain, etc. Okay, meta-analysis of fertility sparing treatment in early cancers show that there is some regression rates of as high as 76% in this meta-analysis of 34 observational studies. However, relapse is very high, 40%, and level rate is unfortunately only 28%. Right, so we have to inform patient what's international rates like. There are other regimens that have been studied, right, using label nurses for IUCD alone, for example, like Mirena, but the what I call the response rate is actually very low, 46%. However, the what I call the double progesterone dual treatment methods using oral progestogens as well as Mirena has been shown to have a very good regression rate of just 87.5% in some studies that was done previously. And in Russia, they also report using GnRH, right, and the Mirena together with a good response rate of 72%. So that means a dual treatment method may be better than using a single hormone method. And in Singapore, we also practice. We always start off with Megace first. If it doesn't work after 3 months, right, we will resample again. But if the cancer is there, then we will escalate to a dual treatment method. Median time for regression is about 6 to 9 months. 6 to 9 months. If beyond 9 months and the patient still has cancer, then we better call it a day and tell the patient that that's treatment failure and we will go on to do a hysterectomy for the patient. How safe is it? So about 3.6% of patients actually had ovarian cancer on follow-up. Either it's metastatic or to be a primary cancer. Why? Because in studies done previously, about 5% of patients do have synchronous cancers of the uterus and ovary at the same time. So that's this risk. So patient must inform of this risk. And then on follow-up, about almost 2% of patients may get upstaging of the cancer if they, you know, if they fail treatment after about 6 months or 9 months, right? The number is still small, it's only about 2%, but they have to be aware of this risk of upstaging. Personally, I had 1 or 2 cases when I was in KK last time that was upstaged from stage 2 and stage 3 after conservative treatment. So this is a risk that we have to document because it's a matter of life and death for the patients. Mortality is fortunately low, right? 0.36%. So if the patient does have a successful regression of the cancer, well, then we usually advise them to quickly go and see an experienced IVF specialist who has experience with treating cancer patients for IVF. And then if the fertility is delayed, because some patients that we have, unfortunately, are not married, right? But they want to preserve the fertility, then no choice, we will continue treatment, right? Continue the treatment. Usually we put Mirena in to prevent the cancer coming back, and then we have to repeat the biopsy every 6 to 12 months, right, to make sure there's no relapse. However, if there's any treatment failure or the patient's chronic family, generally we advise them to have a hysterectomy after that. Okay, lastly, I just want to touch a bit about the new PICO staging that has been released about less than 2 years ago, right? They made it a bit more complicated. But in general, for staging of endometrial cancer, there are only 4 stages. Stage 1 means the cancer is confined uterus. Stage 2 is if the cancer is spread to the cervix, or if there's substantial lymphovacuole space invasion, or if it is of a high-grade cancer with myometrial invasion. Stage 3 means it has affected the ovaries or affected the lymph nodes, for example. And stage 4, of course, is when the cancer has spread out to other areas, really, the bladder, peritoneum, the intestine, or even lungs, bones, etc. So it's actually 4 stages. But what happened in 2023 is that FIGO has actually doubled the substaging of cancers for certain reasons. Okay, but I want to draw attention to the early stage cancers, right? The early stage. Okay. And another thing also I want to draw attention to is that for endometrial cancer, we know there are four groups now, molecularly, right? So molecular testing has showed that there are 4 types of endometrial cancer in regards to histology. And what 4 types are based on mutations, right? You got POE mutation, you got those with MSI high tumors. This group of patients associated with Lynch syndrome. And then we do have the P53 mutated cancers, and we have those which have a non-specific molecular profile cancers. Right? There are 4 distinct groups now. This is irrespective of the FIGO staging, right? How do they merge the 2 together? So the things, right? So molecular staging, right? This is a second staging for FIGO cancer. So where resource is available, especially in developed countries now in what we call the top cancer centers around the world, have moved on to molecular staging for early endometrial cancers, right? So for patients with early endometrial cancer, we usually encourage patients to actually go for this molecular profiling to look for any of these mutations. Why? You see, if the patient is found to be POE mutated patients have very good prognosis. Immediately, they are downstage to stage 1A, the earliest cancer, regardless of whether is it so-called aggressive storage like clear cell or something, but they are already downgrade to stage 1A, which is fantastic, regardless of anything. However, if the patient has a P53 cancer, right, and that's not good. Automatically, they're upstage to stage 2C cancers. So it's actually the only 2 molecular stagings only, right? Whether they're POE mutated or whether they're P53 mutated, right? How does it affect the management? If the patient is POE mutated, no need for the treatment. Oh, we just observe. So we've been doing this in Singapore in the last 1 year already. And I have some patients who are very happy because they went for this testing. Recently I just had one last month. She had a stage 2 cancer just based on the histology of it. So let's go for radiotherapy. But I discussed with her about doing molecular staging, and she agreed. And fortunately, she was fully mutated, and she was very happy because she didn't go for any further treatment, just observation, instead of going for necessary radiotherapy. But conversely, I had patients who originally had stage 1, so-called high-grade cancers. But stage 1 high-grade, usually we just need to give a bit of radiation, right? So they also went for hoping it was PE, but unfortunately, it came back as P53 mutated tumors. But this means the cancer is highly aggressive, high chance of recurrence. So for this group of patients, unfortunately, we have to refer to our medical oncology colleagues to discuss about what is the role for systemic chemo and then followed by radiation. So we have to escalate the treatment for this group of patients. For patients with DMMR, NSMP cancer, that means the so-called Lynch one, Lynch, they could be Lynch syndrome carriers, and those with non-specific molecular profile cancers. There's no change in the science stage of treatment, which means that if they were actually stage 1C, we will manage it as well as stage 1C. That means patients with walk radiation. So it doesn't change the stage, but at least we know what is the molecular profile. Especially for the DMMR or the MSI high group, because in this group of patients, if they ever recur in the future, they are suitable for immunotherapy, for example, because immunotherapy is suitable for patients with this type of application. Okay, so that's end my talk, and thank you very much for your attention.